Hello everyone, my name is Meena Ramchandani. I'm an infectious disease physician at the University of Washington in Seattle. This podcast is dedicated to a STD literature review for healthcare professionals who are interested in remaining up to date on the diagnosis, management, and prevention of STDs. A question that comes up in my discussions with both healthcare providers and patients alike is, should we be doing extragenital testing for STIs in women, similar to what is recommended for MSM? What is the data on this, and how should this be implemented is a frequent question that comes up. Extragenital testing for gonorrhea and chlamydia in women in the past was not recommended in the US, as the previous data for extragenital screening in women was controversial. The new 2021 STI treatment guidelines, which I encourage you to take a look at, were just released by the CDC. They state that routine urogenital screening for chlamydia and gonorrhea is recommended on an annual basis for sexually active females younger than 25 years of age, as well as older women with specific risk factors. The new guidelines also now recommend that extragenital chlamydia testing at the rectal site and gonorrhea at the pharyngeal or rectal site can be considered for females on the basis of reported sexual behaviors and exposure. So let's go through a few articles published on this topic with an emphasis on oropharyngeal testing. This first article for review was actually referenced in the 2021 STI treatment guidelines and was also published in the journal Sexually Transmitted Diseases in May of 2019 by Dr. Bamberger and colleagues. It was titled Extragenital Gonorrhea and Chlamydia Among Men and Women According to Type of Sexual Exposure. The authors evaluated the prevalence of gonorrhea and chlamydia at pharyngeal and rectal sites among all women and men who engaged in receptive oral or anal intercourse and who were evaluated at the Kansas City STD clinic from 2012 to 2014. Now, during this time period, nucleic acid amplification testing for both gonorrhea and chlamydia was done at sites of pharyngeal, rectal, and urogenital exposure among all men and women who came to this clinic. Now, for this summary, I'm going to focus on the results on the 100 MSM, or men who have sex with men, and 3,800 WSM, or women who have sex with men, that they evaluated in this study. The authors found that rates of pharyngeal gonorrhea were 8.5%, rectal gonorrhea 15%, pharyngeal chlamydia 3%, and rectal chlamydia were 17% in MSM. These rates were lower in WSM, at 4% for pharyngeal gonorrhea, 5% for rectal gonorrhea, 2% for pharyngeal chlamydia, and 12% for rectal chlamydia. In terms of the percent of extragenital positive tests, with a negative urogenital test, or potentially missed cases if only urogenital testing had been done. Now for MSM, 82 to 92% of those with a positive extragenital test for gonorrhea and chlamydia also had a negative urogenital test. For WSM, 23 to 35% of the women with a positive extragenital test for gonorrhea or chlamydia had a negative urogenital test, so a lot lower than the MSM population. They found that younger age, compared with those 45 years or older, was associated with an increased risk of positive pharyngeal gonorrhea in all groups, and a greater number of sexual partners in the last 3 months increased the risk of having a positive gonorrhea result. This was true for pharyngeal gonorrhea among MSM and rectal gonorrhea among both MSM and WSM. Overall in the study, the majority of cases of gonorrhea and chlamydia in MSM, so 80 to 90%, would have been missed had extragenital testing not been performed, because the urogenital tests were negative at the time of the encounter. They also found that about 1/3 of the cases of extragenital gonorrhea and chlamydia in WSM would have been missed had only urogenital testing been done, so a little bit lower than the MSM population. These are higher numbers than previously reported in the literature, and this might be due to the specific population that they studied. The authors remarked that they did not perform a cost-effective analysis, but the study does add to the growing body of literature that extragenital gonorrhea and chlamydia infections do occur in women with a specific exposure and may be missed if urogenital testing is done alone for these individuals. Now, the percentage of positive tests isn't as high as in the MSM population, and so personally I believe that extragenital testing in women for gonorrhea and chlamydia should probably depend on your patient population, the individual's sexual exposure, as well as your clinic's capacity to do these tests. The second article I'd like to discuss was published in the Lancet Infectious Diseases in June of 2021 by Dr. Van Leer and colleagues and is titled Routine Universal Testing versus Selective or Incidental Testing for Oropharyngeal Neisseria gonorrhea in Women in the Netherlands, a retrospective cohort study. Now, in talking about this study, I'd like to first point out that while the current guidelines in the Netherlands advocate for selective STI testing based on sexual behavior or risk groups in women, the criteria for selective testing evolved over time, and different STI clinics in the Netherlands had different clinic practices for oropharyngeal gonorrhea testing in women. So in this retrospective cohort study, they used surveillance data from 63 clinics in the Netherlands over a long period of time. This was from 2008 to 2017 to evaluate oropharyngeal gonorrhea in women. So the authors compared the prevalence of oropharyngeal gonorrhea in women who attended clinics that offered routine universal testing, and that was defined by greater than 85% of women tested per clinic year, versus selective testing, which was defined as 5 to 85% of women were tested, versus incidental testing, which was less than 5% of women were tested in that clinic. The authors found that the prevalence of oropharyngeal Neisseria gonorrhea was 1.4% in the routine testing group. That came out to about 700 positive tests out of 50,000 tests that were done in the routine testing group. This was compared to 1.4% in the selective testing group, with a p-value of 0.68. In the selective testing group, that came out to about 1,800 positive tests out of 132,000 tests that were done overall. Both of these were then compared to the incidental testing group, and in the incidental testing group, the prevalence of oropharyngeal Neisseria gonorrhea was 2.8%, so a lot lower, which came out to only 30 positive tests out of around 1,000 tests that were done, and this had a p-value of less than 0.0001. Now, oropharyngeal-only Neisseria gonorrhea infections, which are those infections with a negative urogenital and rectal test, was diagnosed in about 48% of the positive tests in the routine testing group, 53% in the selective testing group, and 60% in the incidental testing group. But remember, in the incidental testing group, there were only 30 positive tests, so this number only came out to 18 out of the 30 positive tests. The authors then extrapolated the prevalence of oropharyngeal gonorrhea for the routine testing group, so it was 1.4%, and then applied this to all visits defined as selective testing, including those who never received oropharyngeal testing. And the authors estimated about 6,200 oropharyngeal gonorrhea infections based on this applied prevalence data. They then looked at how many oropharyngeal infections would have been missed had selective testing only been done, and found it to be about 4,300 infections, or 70% of the infections overall. Now, risk factors for oropharyngeal gonorrhea were being notified of any STI, that was an adjusted odds ratio of 2.1, reporting any sex work, adjusted odds ratio of 4, and having concurrent genital, an adjusted odds ratio of 52, or anorectal, an adjusted odds ratio of 2.6 gonorrhea infection. Now, I know this was a lot of numbers, but this was a great study because it looked at different testing strategies for oropharyngeal gonorrhea in women, which right now differ by country and healthcare provider practice. The authors conclude that selective testing has the potential to miss a lot of oropharyngeal gonorrhea infections in women. Now, although this might be correct, I think it's tough to come to this conclusion for several reasons. The information comes from surveillance data. It's unclear how selective testing was implemented in these clinics, and some of these infections would have been caught with urogenital screening anyway. So I'd like to see more data in this area, as well as information of cost effectiveness and the impact on sexual health outcomes or transmission, given that the prevalence of oropharyngeal gonorrhea in women is low overall. The third article to discuss was published in Sexually Transmitted Infections in March of 2021 by Dr. Dukers, Mers, and colleagues. It is titled Oropharyngeal Chlamydia Trachomatis in Women, Spontaneous Clearance and Cure After Treatment, FemCure. The authors evaluated women with vaginal or rectal chlamydia infection in the Netherlands at STI clinics from 2016 to 2017 as part of a prospective cohort study. The clinics applied selective oropharyngeal chlamydia testing by nucleic acid amplification test 1 week prior to treatment in some participants, just before treatment was given in all participants, and then 4, 8, and 12 weeks after treatment in a smaller proportion of participants. Now, 1 week prior to treatment, 241 women were swabbed, and 30 of those women were diagnosed with oropharyngeal chlamydia. The authors found that 15 of these women, or 50%, were negative when they had tested again just before treatment, suggesting spontaneous clearance was common. These women had not yet received antibiotic therapy. At the visit for treatment of vaginal or rectal chlamydia infection, a total of 560 participants were tested at the oropharynx, and 46 participants, or 9%, were found to be positive for chlamydia by NAT, or nucleic acid amplification test. The authors also tested for viable chlamydia, and only 12 of the 46, or 26%, were noted to have viable chlamydia in the oropharynx. Now, this was a test I didn't really know about before, and what they do is they look at viable or viability PCR, which indicates the presence of DNA from intact chlamydia organisms. Of these 46 women, 36 had a follow-up oropharyngeal test at week 4, and 97% were found to be negative, although it's unclear if this was due to antibiotic treatment or because many of the samples had non-viable chlamydia found at the oropharynx. This is an interesting study. It brings up the question of the clinical importance of treatment of oropharyngeal chlamydia infection in women, as spontaneous clearance can possibly occur, even up to 50% of individuals. It also discusses how chlamydia found at the oropharynx can possibly be non-viable. To conclude, I'd like to summarize some key points from the session. Isolated extragenital bacterial STIs do occur in women, although the prevalence seems to be lower than that in MSM. Selective oropharyngeal gonorrhea testing in women can be implemented based on risk factors and can identify a substantial number of infections. Although universal screening might pick up more cases, it's not really clear how cost-effective universal testing would be, and if there is any impact on sexual health outcomes or transmission. Oropharyngeal chlamydia infection in women can spontaneously clear, and then the new 2021 STI treatment guidelines published by the CDC recommend extragenital chlamydia testing at the rectal site and gonorrhea at the pharyngeal or rectal site, which can be considered for females on the basis of reported sexual behaviors and exposure. Now, that being said, many of the NAT tests pick up both gonorrhea and chlamydia, so if you find chlamydia at the oropharynx inadvertently, go ahead and treat that infection. This is what we're doing in our own sexual health clinic. We consider pharyngeal screening if women with certain risk factors report giving oral sex, or rectal screening if they report receptive anal sex, regardless of condom use. Thanks for listening and have a great day. This podcast is brought to you by the National STD Curriculum, the University of Washington STD Prevention Training Center, and is funded by the Centers for Disease Control and Prevention. Transcripts and references for this podcast series can be found on our website, the National STD Curriculum, at www.std.uw.edu.